So thank you for inviting me to this truly international group. It's very exciting. So most women have nausea and vomiting of pregnancy, and even animals can have nausea and vomiting. For example, this gorilla here was so nauseous that she couldn't even eat her favorite biscuits during her pregnancy. Hyperemesis gravidarum is at the very severe end of the clinical spectrum, the worst 2%, and is characterized by severe nausea and vomiting where other causes are excluded, that affects daily activity, and has clinically significant impairment of oral nutrition and hydration. It's generally defined by over 5% weight loss from pre-pregnancy weight and electrolyte imbalances, and requires treatment. I'm going to talk about the maternal and fetal outcomes, etiology, and management. Maternal morbidity is significant, and there has also been mortality in this century. A third of women report suicidal ideation because of the severity of the disease. And in my study, a quarter of women lost more than 15% of their pre-pregnancy weight, and 22% had symptoms lasting until term, making it a form of starvation in pregnancy. 18% of women had full criteria post-traumatic stress disorder following their HD pregnancy, especially when symptoms lasted all 9 months. And over a third of women reported that they did not want to have any more children because of the severity of the disease and the high recurrence risk. Detached retinas, pneumothorax, and esophageal tears and rib fractures have all been reported in my study because of the violence of the vomiting, and liver, kidney, and gallbladder dysfunction can occur because of the prolonged metabolic dysfunction. Maternal deaths that have occurred in this century have been related to nutritional deficiencies. Nutritional deficiencies are common in HD pregnancies, and when they get severe, the patient can have a thiamine or vitamin B1 deficiency that can lead to Wernicke's encephalopathy, which is classified by the triad of symptoms: ataxia, ocular, and mental status changes. Another cause of death can be from another common problem in HD pregnancies, electrolyte disturbances, which in severe cases can lead to hypokalemia, prolonged QT intervals, and cardiac arrest. Thromboembolism and thyrotoxicosis have also occurred secondary to HG. There's also significant fetal morbidity and mortality. First of all, 9% of the participants in my study decided to have a therapeutic termination when they were not offered ondansetron. There's an increased risk of preterm birth, small for gestational age, low birth weight, smaller head circumference, a significantly reduced total cortical volume and area in children is associated with the increased risk of neurodevelopmental delay and autism spectrum disorder, and vitamin K deficient dysmorphology, or the Binder phenotype, shows directly that in the case of HG, the baby is not always getting everything it needs from the mother. Going into the cause, I decided to use a genetic approach because decades of research had failed to find the cause using other methods. It's commonly been assumed to be caused by the pregnancy hormone HCG, or psychological, with little scientific evidence to support this. It's highly heritable based on twin studies and familial aggregation studies. There's a 17-fold increased risk of having HG if your sister had it. And a genome-wide association study approach to the etiology is unbiased with respect to which genes are involved. So that type of study is going to scan all the genes, including the gene for HCG, its receptor, and genes that are associated with psychologic problems. I partnered with the personal genetics company 23andMe, and we scanned over 15 million variants in over 17,000 participants. And we found that the placenta and appetite gene GDF15 was the greatest genetic risk factor with a p-value of 10 to the minus 15 when we looked at the extreme ends of the clinical spectrum, 1,300 women with HG and 15,000 women with no nausea and vomiting at all. We then did a second scan where we included women in between with slight, moderate, and severe NVP, as well as the extreme ends. And that in that scan, GDF15 also came up as the greatest risk factor, even more significantly with a p-value of 10 to the minus 41. In addition, in the second scan, the receptor for GDF15, GFRAL, showed up, further implicating this pathway. We then did a third analysis called a conditional analysis, where you take away all the variants around a locus, in this case GDF15, that are inherited from the same ancestor, inherited together. You remove them, and in that case we found a second variant that's inherited separately from a separate ancestor that was also in GDF15, providing, again, even stronger evidence that this hormone is associated with HG. GDF15 is a hormone that is expressed at the highest levels in the placenta and activates the vomiting center of the brain. It increases 40-fold in the first trimester. Higher blood levels are associated with HG hospitalization, antiemetic use, second trimester vomiting, and a female fetus. GDF15 promotes weight loss, vomiting, and reduces food intake in animal models, likely through a different mechanism than the 5-HT3 receptor. Inhibition of GDF15 restores appetite and weight gain in animal models. Abnormal overproduction of GDF15 in cancer drives cancer cachexia, which has very similar symptoms to HG, characterized by over 5% weight loss, nausea, muscle wasting, and inability to eat. GDF15 is also upregulated in response to nutrient deficiency, long-term fasting, hyperthyroidism, and infection independent of pregnancy. So I showed that the gene is associated with HG, but what about the hormone itself? Well, patients hospitalized with HG at 12 weeks gestation have a 5 nanogram increase in circulating GDF15 compared to patients with normal or no nausea and vomiting of pregnancy. By contrast, patients with cancer cachexia have a 2 nanogram per mil increase compared to controls. So patients with cancer cachexia are dying from their cachexia. So when patients with HG who have a 5 nanogram per mil increase compared to a 2 nanogram per mil increase say that they feel like they're dying, it probably is because they feel like they're dying. This is the possible model I have for the role of GDF15 in HG pregnancies. So if women have some sort of predisposition towards having a higher level of GDF15 than normal, that's genetic or otherwise, then they'll have slightly higher than normal GDF15 circulating and reaching their brainstem. And that activates the brainstem to cause appetite loss, taste aversion, nausea, and vomiting that then can lead to nutrient deprivation, long-term fasting, hyperthyroidism, and potassium depletion. And all of these factors, independent of being pregnant, have been shown to increase levels of GDF15. In addition, there can be environmental stressors such as an infection, which also is known to increase levels of circulating GDF15. So when you have increases of all these factors, you can then get this downward spiral towards HG. So we also did a replication study of patients independent of the patients that we had from 23andMe, and confirmed that the 2 variants in GDF15 and the 1 in GFRAL are indeed associated with HG. We also showed that the hormone levels may be increased in HG pregnancies. And other researchers have shown that GDF15 activates the brainstem and causes nausea and vomiting in animal models. And GDF15 and GFRAL therapeutics have been developed for cachexia and chemotherapy nausea, and they restore appetite. So there is a larger body of evidence to support a role for GDF15 in HG than for any other theory at this time. Going into management, our Nature Disease Primer has a protocol for management that I suggest you review. In addition, the HER Foundation has many tools, including this algorithm that is very detailed for going into managing HG patients. The HER Foundation has also available for free many different tools to manage your HG patients. One of them is the HELP score, which is designed specifically for HG, and it performs better than the PUC score in identifying patients with severe symptoms requiring intervention. The HELP score is included in our free HG Care app. The HG Care app improves accuracy in scoring the HG level and in communication and care. The patient can download the app for free and enter their symptoms, monitor their care, and then there's an insights page that summarizes their progress over time, and it can be shared with their provider if they want to, so that the provider can monitor their care, monitor their progress, and determine whether they need a change in their treatment. The app has been used and downloaded in over 50 countries. I show this slide. This is a comparison of Zofran with two separate control groups. So in this study, we used both HG with Zofran compared to HG patients who did not have Zofran, as well as HG with Zofran versus no HG and no Zofran, and looked at outcomes. And the study showed that really medication safety is a risk-benefit assessment, and that safety studies must use HG with no drug as a control group because HG itself is associated with adverse outcomes. And I suggest providers be wary of safety studies that do not take into account the confounding factor of HG itself. This is unpublished data that shows that medications are really not working well enough. We asked patients, were you able to gain weight after treatment with your prescribed antiemetic medication? Only a quarter of patients said that they were able to gain weight. And remember, these women have all lost weight due to HG. Only a quarter of them had been able to gain weight within 2 weeks of starting their medication. By contrast, 50% of the women who had used marijuana or cannabis-based products had gained weight. So we need to really determine whether cannabis or marijuana-based products are not safe during pregnancy. In summary, there are adverse maternal and child outcomes associated with HG. Make sure to correct for thiamine and potassium levels. The placenta and appetite hormone GDF15 is the most likely cause of MVP and HG. I recommend earlier screening and more frequent monitoring using our treatment algorithms, the HELP survey, and the HG Care app to better communicate symptoms and monitor care. And we need more effective treatments that help women safely gain appropriate weight in pregnancy and alleviate the suffering. And I have many people, my team, my funders, and also the patients that participated in this research. Thank you.
Thank you very much, Marlene, for a fascinating and very important talk again. I think a very important point that comes out is how severe HG can be for women and the importance of knowing what treatment can be used. We have a few questions related to GDF15, which I'll start with. One, firstly, did you find any ethnic variation in GDF15 levels in symptomatic women?
So that's a good question. We have not, the study that I looked at was only in women from Germany. It was a German cohort. I'm now doing a study that's primarily in Hispanic women. So I will have the answer to, at least those two groups. I encourage anybody who has blood samples stored. I've been trying to get people from all over the world to please measure, instead of HCG, measure GDF15 in your sample so that we can get an answer to that question a little bit faster. But I'm working on it. I'm also working on looking at the genetics in different ethnicities as well. So we should have that answer coming hopefully in the next couple of years.
Fantastic. A very small plug, as you know, we're funded to do a genetic collection in the UK. Any British people listening, we have just opened to recruitment. Please refer your cases to us. But to come on as well, is there any phenotype associated with the GDF15 genotype outside pregnancy?
So it is associated with higher circulating levels of GDF15 and higher circulating levels of GDF15. It's basically a stress hormone, a physical stress hormone. So anytime you have something wrong with any organ in the body where it's under some kind of stress, it's going to start to produce extra levels of circulating GDF15. So it's actually now even used as an indicator, or going to be used, I think, as an indicator of what survival. So a patient is more likely to die earlier if they have higher levels of GDF15 for whatever cause, cancer or other causes, heart disease.
There's a question here. Since it is a genetic factor, why do some pregnant women have hyperemesis in one pregnancy and not another? From Nathan from Brazil.
That is a very good question. And I have a theory about that. It's unproven right now, but I'm working on it. So I also have an exome sequencing study, and we have 11 women that have a mutation in GDF15, a very rare mutation, and they have all had HG in one pregnancy and not the other one. And so I'm hoping to collect their children's DNA. And I think my theory is that when the baby inherits the bad gene, then they get HG because it's produced by the placenta, and the placenta is part maternal and part fetal in origin, and the fetal part also produces GDF15. So I hope we'll have that answer once I get the study going, if that is the correct reason.
That will be very interesting. I see that one of our panelists, Magdalena, wants to ask a question.
Hi, thank you so much. That was a wonderful presentation, Marlena. I very much enjoyed it. So at the beginning of the presentation, you mentioned that those pregnancies that are starting with hyperemesis, they later on might develop increased risk for preterm birth, SGA, significantly reduced total cortical volume, and other neurodevelopmental potentially delays. So are you able to quantify those risks in terms of like the pregnancy related risks and also the baby related risks?
So we found a 4-fold increased risk in our study of preterm birth. I'm not sure if that's exactly what you're asking. The increased risk of autism, there was a huge study done by Kaiser, and I think the risk was about 3%. So it's still very small. So, I don't want to scare women because they already have enough to worry about, but it is something that is important for doctors to know so that they take it seriously and make sure the women are getting proper nutrition. Clearly, these women, many of them are not gaining appropriate weight in pregnancy and getting their vitamins, and that can be a problem.
Thank you.
Thank you. Marlena, we're having a lot of comments and questions about ondansetron, as could be predicted. from some countries where guidance is not to use it because of the reports of congenital malformations, and others saying we still do use it, which is a view that I personally would support for a woman with severe hyperemesis, and absolutely agree with you that the risks of HG are likely to outweigh the tiny risk that hasn't been proven in HG cases. Would you like to say any more to that? And I would also like to ask Kathy Nelson-Piercy, who is still here, if she would like to add anything to that as well.
Yeah, so 20% of women in the US are prescribed ondansetron right now. So it's, used very freely, even in women with normal nausea and vomiting in pregnancy. And so the increased risk that they see, one huge study shows that there's an increase of one thing like cleft palate, another one shows an increased risk of heart disease. The fact that they haven't been consistent makes me wary of the results. And as you said, I think the increased risk, it's a risk benefit assessment, like I said, and there are increased risks of an untreated HG pregnancy. Like I said, in the US, 9% of women are terminating if their doctor isn't giving them ondansetron, and that's because the other medications are not working as well. So you need to consider that.
Yes, Kathy, would you like to say anything else to that?
Yes, I mean, the hoo-ha in Europe was sparked by the EMA, the European Medicines Agency, related to one of 3 systematic reviews that Marlena's referring to. And the one that showed the increased risk of cleft lip and cleft palate showed that the background risk is 7 per 10,000 fetuses for cleft lip and cleft palate. And with ondansetron, it was 13 per 10,000. So the attributable risk of ondansetron was 4 per 10,000 pregnancies, which is tiny. And as Marlena says, not even within the systematic review, there were studies that were drug funded by a rival drug company funded, and there were not adequate controls for the disease itself, which probably via micronutrient deficiency increases the risk of malformations in the fetus in the same way that folate deficiency does. Mark's got his hand up.
I would like to just add to that as well, that what you've said about micronutrient deficiency is so important. And I would refer any of you to a very, very good paper that Marlena published demonstrating the evidence for the impact of severe micronutrient deficiency on the developing brain. So it is very important to think about the entire condition. Sorry, I can't see all the panelists, but Mark, if you have...
There's something in the chat. They're all saying 3 to 4%. Is that for the risk of cleft lip, cleft palate? There's loads and loads of comments about that.
Yeah. The general risk of teratogenicity, the principles are you look to see if something adverse happened when you introduced something into the environment. Did it go down when you took it away? Is the timing in pregnancy reasonable for the effect? And is there biologic plausibility? The fact that you're seeing abnormalities in several different types of problems reminds me of Bendectin 40 years ago, where yes, if you give drugs to 1 million women, guess what? 2 to 3% of them are going to have a birth defect. Okay. Unlike drugs like thalidomide and diethylstilbestrol, which all met the criteria of one specific type of birth defect, consistent with the time it was given. For example, with diethylstilbestrol, the maximum period of susceptibility was 17 weeks, which is when the adenomatous epithelium of the vagina turns over to squamous, and DES inhibited that. Women who got it only after 17 weeks basically had no risk. So you got to use extreme caution here. And again, evaluating risks versus benefits. I mean, I sort of made up a term many years ago. We have, teratogens that cause birth defects and litigens that cause lawsuits. This is more of a litigen than it is a teratogen in reality.
Yeah, and going back to the paper that I showed, our paper on ondansetron, when we used the 2 control groups, whereas many of the other studies on ondansetron did not. So we compared to HG with no Zofran, and we found 3.47% birth defects on HG plus Zofran and 3.4%, so almost equal on HG with no Zofran. But our other control group with no HG had the 1% birth defects. So it's really, you really have to do the study right, where you're comparing HG to HG plus or minus the drug.
Absolutely. So I think the important message is, please don't leave your women with HG who are very unwell without treatment. Kathy, I want to move on to one other very important issue that's been raised in the question, which is the suicidal ideation. But do you have a quick point to make related to this first?
I was going to make the point that doctors aren't sued for not treating hyperemesis properly, and maybe they should be. And all those women who terminate their pregnancies, which is what we're going to come on to the suicidal ideation, because their treatment is inadequate. That's the only point I was going to make with regard to Mark's point about litigens.
Yeah, thank you very much. Marlena, before we move on, a question which came in early in your talk was, is suicidal ideation related to HG or just a psychiatric related diagnosis? Where I think the implication here is there pre-existing psychiatric disease, or is it a consequence of HG?
I definitely want to say it's a consequence. I mean, of course, there are people out there that, when you're looking at so many people that might have some pre-existing condition, just like anybody out there could, but the suicidal ideation, all the psychological factors that come up are from the severity of the disease and the severity of symptoms and the prolonged symptoms day after day. Most people can't deal with nausea and vomiting for a few hours and feel like they're dying. If you have to wake up day after day and deal with that with no end in sight, and the way you're treated still in this century by doctors, by your family, thinking that it's all in your head instead of genetic, it really takes its toll on women's mental health.
Yes, I think this is very important, and as Kathy has alluded to, also of relevance to the high proportion of women with HG who terminate an unwanted pregnancy. There was a UK survey in collaboration with the Pregnancy Sickness Society charity, which Melanie Nana, one of our registrars, has just analysed recently, showed very similar rates of suicidal ideation to those you had shown, and termination of wanted pregnancies. So I think this is a major and an important issue.
That was your paper that I was citing there, not mine, but yeah.
So I think we have to move on to the next talk. Once again, a fantastic talk. Thank you very much.